counters anti-Black narratives. And ultimately, it's a space that condemns racism and calls for racial justice. Within this series, we have created spaces for Black researchers and content experts to educate our community unapologetically, for Black students to share their experiences transparently, and for all of us as members of the Stockton community to challenge ourselves to move beyond a comfortable space and into a more uncomfortable arena that calls for self-reflection and respectful dialogue in which we can actually affect change. As you know, today's program is entitled Black Health Matters, with an emphasis on Black physical health and the ways in which it matters within the Black community. Throughout this session, you will hear from Black faculty within the Stockton community, whose research and experiences underscore the Black experience within the medical field. It points out that our lives matter even within this domain, even though much of this conversation started surrounding police brutality. It also matters, it's also pertinent to our health. With that, I will turn things over to Mr. Marcus Johnson, the Director of Residential Education and Student Services, who will introduce to you a short video to give you a glimpse of Black health from the lens of our very own Black faculty, administrators, and staff members.
Good afternoon, everyone, and thank you, Dr. Johnson, for having me. We're so delighted that you all are here and joining us in this conversation, this very important conversation. And as we were speaking about what would go into this event, we recognize the importance of us all sharing our stories and being able to add some context to that. And so we recognize that in doing so, we can speak for hours and days on end about this topic. So we were able to gather a few faculty and staff to share some snippets of their own experiences in terms of Black physical health. So we're going to share this short video with you just to set the stage for today's program and to give you an opportunity to just reflect and see where we're going moving forward. And I'll share my screen now.
Well, they don't go to the doctor, or they won't tell anybody when something. There's a reason for that. It's not in our imagination. There's a reason for that. There's a reason why my grandmother had all these home remedies. Oh, something happened to you, come over here. I have a plant in my house. I'm just gonna crack that plant open and put that on your leg. You'll be fine. Like, it was. That's how I was raised, because this idea of, going to a place that's supposed to care for you and being traumatized in that place.
You remember when you were a kid and you would fall down and you could break a leg, and your grandma would say, just put some mercurochrome on it. like mercurochrome was the cure-all for everything, right? And so that's a unique, funny thing in the Black community, because we didn't have access to go to the doctor or to go to the hospital. And so if something happened, you had to tough it out, or they'd say just go put third-degree burns, go put some mercurochrome on it.
There's been so many negative experience, whether it be with doctors, dentists, or whatever, treating Blacks like they do not matter. And that's why I believe a lot of Blacks refuse to go to doctors, refuse to go to dentists, because of the experiences they had from their families or from their loved ones.
How many times do Black men or women walk into a doctor's office and people don't want to greet them, are afraid to touch them to this day, thinking that something is wrong with their skin, right? Because of the color. There was a lot of cognitive dissonance back in the day, where they thought we couldn't feel pain. That's why they were able to treat us the way they did when we were slaves, because we weren't treated as human. You can do that to them because they don't feel pain the same way. We are suffering the residual side effects of what happened centuries ago. And so because of that, we still don't feel safe showing up in those spaces to address our physical health.
What happened to Serena Williams, and how she had blood clot and almost died when she was having her daughter. And it occurred to me that it really doesn't seem to matter what level of wealth or education you are as a Black woman. That had everything to do with these notions of, Black women, these notions that we can tolerate pain more. I mean, think it had everything to do with that. There's no wonder why generations of Black people avoided, doctors' offices and counselors and all of those kind of medical professionals, because they weren't being heard or cared for.
Thank you, Marcus, for that beautiful video. To start us off, we're going to start with a few student reflections. I have the pleasure of introducing two amazing students to you all. The first one that is going to speak to us today is Sabrina Clement. She is a junior health science major with an interest in nursing. She also has an Africana Studies minor. She is working towards becoming a labor and delivery nurse so that she can address healthcare disparities firsthand. The second student who will be following Sabrina is Arnica Jones, and she is an environmental science major with a minor in Spanish. She is also the president of the Phi Mu chapter of Zeta Phi Beta Sorority Incorporated. Sabrina?
Hey everybody. If you see me looking down, I'm looking at my notes. But I'm really excited to talk about this topic because I feel like disparities within the healthcare system are often overlooked. We talk about police brutality, systemic racism, the failing of the justice system, but the healthcare system fails us too. It's really hard to seek adequate medical care as a Black person. We always have to go above and beyond to advocate for ourselves and like beg for help, really, and it shouldn't be the case. In my life, I've been privileged enough to have a Black doctor who she recommends me to other Black doctors, but my dentist isn't one of those people. And I actually just went, and when he looked at my mouth, it's a little bit damaged because I struggle with anxiety. So I bite in my mouth sometimes. And I told him I'm struggling a little bit lately, and his response was to get a fidget spinner and do something else besides eat my face. So I left feeling like pretty embarrassed, and it just made me feel, sorry, a little nervous. It made me like reflect more on what I want to do, which is become a labor and delivery nurse. And that's because like women go through that every day, and their outcome, they can't just leave like I did. Oftentimes, it ends in mortality, 3.2 times more actually. So that's pretty much what I had to say.
Thank you, Sabrina, for sharing. Arnica?
So my name is Arnica Jones. My major is environmental science with a minor in Spanish. As my pretty friend already said, Danielle Combs. My main thing is health doesn't stop. We're at the office. So my main concern is ensuring that everyone in urban areas have access to fresh fruits and fresh vegetables in order to have a healthy and successful life. I'm from Camden, New Jersey, which a lot of people do not know. That is, it is a food desert. So a food desert is a place where a lot of people in the city do not have access to fresh fruits and fresh vegetables, which is you can see the disparity within the community from transportation to these fresh fruits and vegetables, to having allocating a lot of money to provide for these fresh fruits and vegetables. You can see the disparities within the job market to actually have funds to have these fresh fruits and fresh vegetables. Like I said, it's very like saddening to see like the disparities between Pennsauken, which is like a neighboring town next to Camden, and Camden City, which is like dwindling down to its bare fruits and vegetables. I kind of find it like a strange fruit kind of instance, where if you know who Billie Holiday is, she wrote a song called Strange Fruit, and I kind of feel like I kind of like see the representations of that song and like our access, well, not access, non-access to fresh fruits and fresh vegetables in the city of Camden. That's mostly what I have for you guys today. If you have any questions for me, I could drop my link in the chat. You guys can contact me if you have any other questions about environmental science, sorority life, anything. I'm very open. So I hope you guys have a great day and speak to you guys later.
Thank you so much. The reflections from both students were very important things that we need to think about in terms of what we see as disparities when it comes to the Black community, when it comes to access, and when it comes to treatment by some healthcare professionals. So we're going to move on. We are very fortunate at Stockton University to have several scholars who do their research and teach in the areas of health and healthcare. And so our first two speakers are professors here at Stockton, and hopefully you students will take note of this and know that you have some professors whose classes that you might be interested in taking in the coming semesters. So first we will hear from Dr. Christian Ehebuche, who is Assistant Professor of Business Studies, Management, Healthcare Administration. And then we will hear from Dr. Nicole Milan-Tyner, who is Assistant Professor of Health Sciences. And both, again, have done some very important research that you will hear about today. So we will start first with Dr. Ehebuche.
Sorry for that. Good afternoon. And thank you for that wonderful introduction. I think our conversation today is all about equity, inequality, social justice, because these are the factors that help us navigate the phenomena about Black Lives Matters, and especially when we focus it on health. The purpose of my presentation today, if you don't mind, let me share my slide. Okay. My purpose today is to share the story on Africa's contribution to health and welfare, tell the story on African health-seeking behavior, and of course, to link the past with the present issues about health access, inequality, and social justice. And one of the ways I want to start this story is from a real life experience, because this is an issue that is happening in both sides of the Atlantic Ocean. I happen to have been born and raised in a continent where these first three stories come up. It's a country in Africa where 30% of the population live below poverty level. But in the same country, the president of that country is able to fly overseas when he was sick, stayed 5 months in a British hospital with the presidential jet being taxed at the airport, standby waiting for him for 5 months, just one person. That's also a country in Africa where a minister or a pastor who is supposed to be a religious leader, owner of one of these mega churches, was able to fly to Israel in his private jet with his entire family and some top members and top donors of his congregation to get the coronavirus vaccine, when in the same country, as of now, less than 7% of healthcare workers have been able to get the coronavirus vaccine. A pastor, a religious leader, flew private jets with his congregation to Israel, paid, of course, to get the coronavirus vaccines. It's about a country where a minister, what we call Secretary of State here, was able to fly his entire family to go to Dubai, United Arab Emirates, because he's a Muslim, to be able to get the same vaccines and get the same healthcare standard that they were supposed to share to the community. And these are leaders of that country. Maybe you'll be wondering where this story is going to. Okay. This story is about health disparity. Maybe the difference between Atlantic Ocean African side and Atlantic Ocean American side is that the indicators and the measures might be different, but the impact is the same, that there is a denial of privileges to the majority that might be poor, or to the majority that might have a different color of skin. Why did I make this narrative? Because I now live in a country where the president of the country, when infected with coronavirus, was flown by a helicopter, and in 4 days had 14 physicians taking care of him. And of course, after 4 days, he walked out of the hospital fit. And in the same 4 days, I have experience of Black physicians working 14, 18 hours a day, seeing about 40 to 60 patients that have problems with coronas and were running into emergency rooms. And of course, you can imagine the neighborhood where such hospitals are, and the type of doctors that can make that type of commitment. 14 doctors to one person, one doctor to 40 to 60 patients in the same margin of 40 days. If there's any other thing that we can think about health disparity, this story tells it all. Now, how do I connect it with my researches and my presentations? I would start with what we know about Africa, and then we go back to what we should know about Africa. Remember that Africa is the world's second largest continent and the second populous continent. So that means by landmass and by population is very visible, very contributive. The African region has about 11% of world's population, but with highest rate of death from preventable and policy causes. So people die more from Africa than any other part of the world by causes of death that is preventable. Something that is very shocking and is very comparative with this other side of Atlantic Ocean is that the average life expectancy in Africa as a whole is about 62 years for male and 65 years for female, while the average life expectancy globally in the world is about 7 years for male and 75 years for female. So those of you that by virtue of biological accident are privileged to be born in America, you can imagine why I'm here, because I want to gain those 5 years additional. Now, we are in a situation where the health issue and the health disparity is a global issue. But maybe in the case of the United States, it's more peculiar because this is a country that the rest of the world is looking forward for, to lead the world in fairness and justice. And to find out that this fairness and justice is not equitable, is not distributed evenly. That calls for not only scholarly curiosity, but maybe a spiritual and a passionate call for remedies. What we may not know about Africa, but what we should know, we may not know that we should know, is that Africa is still the cradle of civilization. Civilization started in Africa. If you look at it from religious point of view, what used to be called the Garden of Eden is still a country called Eritrea in Africa today. And if you're looking at it from religious point of view, all the 4 major religions of the world, the 4 of them originated from Africa. Education started from Africa. And even though the Greeks claim the birth of modern medicine, but it's also proved that most of the Greek philosophers studied in the ancient University of Timbuktu. This is according to studies by Professor Henry Lewis of Harvard University on contributions of Africa to the world. That those philosophers and people we acclaim to the ancient Roman Empire all studied in the ancient Egyptian Empire. Where am I going with this story? What is the structure of health inequality and inequity? What is the situation of social justice in Africa? And how has that transcended to our experience in the United States? If civilization started in Africa, that means medicine and health care also started in Africa. But the measures of the disparity are different. When we talk about inequality and the health disparities in the United States, we are looking at this column. If you can see my slide, a lot is focused on race and ethnicity. A lot is focused on social and economic status. A lot of disparities are measured by age. It's measured by location, like the students who said something about Camden, maybe comparing Camden with Westfield or some other more affluent communities in, or towns in New Jersey. It reflects on gender, what is available to women or what is available to men, and so on. The aspect of disability and how we benefit from disability policies and the policies and politics about disability in the United States. And of course, the area that is not said a lot, but it impacts a lot, the aspect of sexual orientation in America. Compare this with Africa, how we measure inequality. Number one thing that counts in Africa is tribalism. And disgracefully, I can tell you this, that in Nigeria, where I come from, the quality of health, hospitals, and the attitude of doctors from a particular tribe towards the people from the other tribe can show clear discrimination. And yet, no person talks about it. Maybe that is the difference, that here we are talking about it. But down there in Africa, maybe not many people are talking about it. It may be talked about only by the elites in the universities, and that is it. Okay. The issue of nepotism, that like the story I gave, these ministers, including the religious leaders that can afford it, picked up their family members, flew out of the country to get the vaccines. And they left behind the tithe payers, people who contribute to the churches and to the mosque that make them great, they left them behind. And of course, they are the same people who call the government to provide them everything when they don't encourage the tithe payers to pay tax that can improve this infrastructure in the continent. Okay. The issue of ecclesiasticism, a lot of health disparity is tied directly to the faith and belief and the teachings of the religion. Particularly if we talk about health equality to men and women. Both dominant religions, Islam and the Christianity, regrettably did not favor women and women's health. And automatically politicians capitalize on that not to make emphasis on equality of health on gender basis. The aspect of xenophobia in Africa is unbelievable. That even myself from West Africa and from Nigeria, if I go to Ghana for treatment, it's likely that in the same line that they will pick up somebody from Ghana first to be treated before somebody from Nigeria. And the reason is just on xenophobia. Unless myself from Nigeria, I'm well over richer than every other person in Ghana, then my money will talk. I will get better attention than any other person. So the issue of inequality in Africa, it can be the story of classism. And that classism can be measured from birth rights or ethnicity, where you are born, where the type of family you are born from, or the area of the country you were born in. It can have to do with genderism and sexism, and of course, homophobia, which is becoming an issue that the world should call out for, the way people are treated. And I want to share a very unfortunate story about this. A couple of years ago when Obama was running, my parents from Nigeria were calling me every day and telling me, make sure you campaign, make sure you vote and everything. And believe it or not, my father heard that Obama won the election before I heard about it. He was at work trying to get the story. But when I went back to Nigeria recently, to be precise, around March last year, I discovered that Obama was not popular to my father. And I was particular about it, and I asked him why. And all what he told me is, well, he supported same-sex marriage, and Donald Trump did not. And therefore, you have to vote for Donald Trump. I laughed. I told him, well, Dad, you didn't make me American citizen. So when I go back to America, I decide how to vote. It looks like a personal story, but it can give us room for conversations and discussions on what creates disparity, what creates inequality, and how we can improve on these issues.
Dr. Ibuche,
yes.
your information is phenomenal, but we're gonna have to come back when we do our Q&A.
Okay.
For the sake of time, we have to move on to Dr. Malan-Tyner.
Can I have 1 minute just to explain this slide? 1 minute.
Okay.
So if we come down to behavior, we have three collapse of forces that determine our health behavior, and the same three forces determine the disparity. One is the conventional medicine, osteopathic medicine, as it is right now in Africa. Another one is the traditional medicine, which has been in existence forever. And the last one is spiritualism and the faith-based divine healing. The clash of these three creates the confusion on what we can define as health inequality or disparities. And in our conversational discussion level, I should be able to explain why this creates the disparity in healthcare. Thank you.
Thank you so much. Dr. Malan-Tyner.
Yes, I'm here. So let me share my screen. I just want to, for the next couple of minutes, take an opportunity to discuss with you my objectives. And I want you to walk away from this presentation understanding those key terms as they relate to culture, cultural norms, understanding how these cultural norms influence how healthcare is utilized, and then recognizing how cultural norms impact the Black community's perceptions and trust of the US healthcare system. So according to Shine, culture relates to norms, values, behaviors, rituals, traditions, the importance of stability, as well as a shared history and shared learning. And that shared history and shared learning is passed down from generation to generation. Culture becomes very important, particularly as it pertains to the Black community, when we talk about survival, when we discuss the growth of our community, and when we discuss having to adapt to certain circumstances. And we can point to those circumstances as being, particularly within the Black community, as having been marginalized, as having experienced racism and other forms of discrimination. So I want you for a moment to just think about cultural norms. So we've already gone over culture, but cultural norms. Cultural norms relate to whatever is normal to you, what is customary to you, what is normal to your family. So maybe within culture, you can feel your culture through your faith. You can see it in your family gatherings. Maybe you can taste it in the foods that you eat and the recipes that you prepare and pass down, or maybe that your grandparents or parents have passed down to you. You can also feel it in that sense of pride that we have within the Black community, as well as those shared experiences. And I'm going to talk a little bit more about those shared experiences as we move on. But I also want you to know, because see, sometimes people tend to think that the Black community, you can apply one concept to the Black community, where in fact there are distinctions within the Black community. And I say that because there are multiple subgroups that make up our community. So it's very important that you know that as we move forward. So think about those cultural norms within your own family. So we've already heard in reference to health disparities and those determinants that create those health disparities. But cultural norms are among the many social determinants that influence the health and healthcare conditions of individuals. More specifically, cultural norms of the Black community have gone unrecognized by the healthcare community as factors within our own well-being. Okay. So think about those customs and those traditions, again, those beliefs and values that you have within your own home. Think about the behaviors that you've adopted from the generations before you. But I really want to focus on that shared history and that shared experience that individuals within the Black community have in common and that we experience. So our culture, again, a part of our culture is our shared history. A part of that shared history is the distrust of the healthcare system that we have. And if I could just take a moment, because I didn't want to put up the explanation, but I wanted to share it with you. When we look to healthcare and our distrust in the healthcare system, this began long ago. And we've already heard, I believe Marcus commented within the video early on, that it started during times of slavery. And more importantly, and just to give you an idea, physicians in the South contended that Black people possessed an anatomical features that justified our enslavement. So in other words, how we were built, the color of our skin, all lent to a way that we were less susceptible to contracting certain illnesses, certain diseases. We were also considered inferior and inhuman. And even back during slavery, it has been documented that we have been used as experiments, whether that is experiments for, quite frankly, exposure to heat, whether that has been experiences where our slaves who were women were actually used as experiments for gynecological purposes. So this began long ago, okay? So we need to understand that, and a lot of communities need to understand this distrust didn't just happen. This was over a course of time. Now let's fast forward to the Tuskegee syphilis trial. Now, I don't want to assume that all of us know what that trial is. So if you just give me a moment, I want to read some information to you. In 1932, the Public Health Service began a study to record natural history of syphilis in hopes of justifying treatment programs for Blacks. The study initially involved 600 Black men with 399 with syphilis and 201 who did not have syphilis. The study was conducted with the benefit of was conducted without the benefit of patients' informed consent. So here you have these men who are being treated, and researchers told the men that they were being treated for bad blood. Now, anybody who knows anything about the Black community knows we've used the term bad blood in the past. Bad blood, in fact, can relate to ailments involving anemia or fatigue, but they were never told about their illness, nor were they ever treated for their illness, which was syphilis. In exchange for this part in this study, these men received medical exams, free meals, and unfortunately, burial insurance. Now, as time goes on, this is 1932, as time goes on now, penicillin has been discovered. Penicillin not only was discovered, but penicillin was used in the treatment of syphilis. Those men were never treated with penicillin or any other treatment for their ailment of syphilis. So again, we oftentimes wonder why there is a distrust in the healthcare system for Blacks. It started back in slavery, fast forward to 1932 to Tuskegee. But there are also, this is a very layered experience that we've had. Now move on to segregated healthcare. We've often talked about hearing our schools were segregated, often hearing about our neighborhoods were segregated. And we also know that there was a distinction between what water fountains you could use, where you could sit on a bus, where you could sit in a movie theater, and I can go on and on, but I won't. But segregated healthcare also came with its own set of challenges. Facilities were not as in the proper conditions as those health facilities that were utilized by whites. Okay. Another layer to our distrust of the healthcare system, to the Black community's distrust of the healthcare system, are medical deserts. I heard Arnica talk about food deserts. We also have to remember that there are medical deserts as well. And those medical deserts are essentially, there is no access to healthcare facilities within the Black communities. You will see some more or less in the urban centers that are built up, but you won't necessarily have that access within a Black community where you can utilize healthcare services. And lastly, I want to take a moment to talk about the biases and the preconceived notions held by healthcare professionals. When we talk about biases and when we talk about those preconceived notions, we are often talking about stereotypes that are held by physicians of Blacks. We're also talking about not having an understanding of our culture. So now we're going to go back to our culture. I heard Dr. Allison talk about home remedies. We've also heard conversations about the types of foods we eat. But without knowing those origins behind the types of foods we eat or why we even started eating those foods, it's going to be very difficult for the healthcare profession to connect with individuals within the Black community. Without realizing why we've used home remedies, simply because there was a time where we could not afford to go to the doctor. Without having that information and without the healthcare profession understanding that that's a part of our culture, again, they're not going to be able to connect to the Black community. In addition, the role of faith, our faith-based. I can remember times when my elders they might have been discussing a healthcare condition that one of them had. And the first thing that they said, well, you have to leave it in God's hands and leave it there. So now we're not having discussions about going to the doctor. We're having discussions on, don't get me wrong, pray on it, but you also have to go to the doctor as well. So we're having these discussions, and the healthcare profession is not quite understanding why we hold these types of beliefs, why we hold these types of traditions within our families, within our community. I'm gonna end on these two buzzwords. They're buzzwords that we use throughout healthcare. They're buzzwords that we use in as far as our own professional development. One of those buzzwords is cultural competency. It is not always our responsibility to educate our healthcare profession. It is their responsibility to educate themselves. Cultural competency speaks to the health professional first realizing that they do not know everything as it pertains to their patients, that they are willing to accept that there are cultural differences, even if those cultures don't align with their own. And most importantly, cultural competency relates to self-reflection. And right now we are in the midst of health professionals being more culturally competent. But that self-reflection piece is extremely important. And I know we have some health science majors here. When we self-reflect as health professionals, we need to identify what it is that might be a bias, or what it is that we bring to the table where we have preconceived notions of our patients. What barriers are we putting in place that no longer allow us to provide optimal care to all of our patients, including those patients who are Black? So that's the first buzzword, but that's their responsibility on the part of the healthcare system. I also want to speak to you about the importance of self-advocacy. We also need to come to the table willing to advocate for ourselves. And that is the one thing that I don't see a lot of young people willing to do all the time, because sometimes we are often, well, I can't say we because I'm not young anymore. Sometimes we are often intimidated when it comes to professionals. Sometimes we feel like our intelligence, we can't match their intelligence. One last experience that I want to share with you. I went to the doctor, and my visit to the doctor was for post-surgery. But I knew when I went to the doctor, I was going to have to discuss, or he was going to discuss with me, medication that I needed to be put on. So me being me, I did my research. I'm coming in as I'm going to advocate for myself. When the doctor started to discuss with me the medication, I said to him, well, I read about that, but I also read about these possible medications as alternatives to what you're suggesting. He hit the roof. The first thing he said to me was, what do you mean you read? Now I'm master's prepared. I've already gone to college. I have my master's. I hadn't yet earned my doctorate. But that is the first thing he said to me. What does it mean? What do you mean you read? I was floored. I was absolutely floored. And he treated me like I was this small. So we're going to be, now all of us are college educated. It doesn't matter the color of, it doesn't matter how many degrees you have. You still have to advocate for yourself. And, it's often discussed, particularly as it pertains to the Black community, that while you may be you may be college prepared, all that is seen is the package in which we walk, which is the color of our skin. I'm going to again though challenge you to please advocate for yourself. And let's start to, that distrust of the healthcare system didn't occur overnight. So it's not going to be, we can't undo it overnight. But we all have a part to play. And I want to thank you for your time. Thank you.
Thank you so much, Dr. Eobuche and Dr. Milan Tyner. Dr. Milan Tyner's presentation, which was beautifully executed, is the perfect segue into our next section. What it did was it gave an accurate depiction of the historical context that addresses the distrust amongst communities of colors and healthcare. And so we recognize that we are in the middle of a pandemic, and COVID-19 has disproportionately affected Black and Brown people, not just with those who are infected, but at a fatal rate. And as such, we have to address those issues. We see that there are vaccines that have been developed, and what we're hearing, which is a common thing as we get now, is that people, Black and Brown people, have concerns about this vaccination because of things that have been done to us in the past. And so this next video is a video that was found that sort of addresses some of the myths around the vaccination to help us really understand the context of what's happening, how it's been developed, and how we can move forward. So again, thank you, Dr. Milan Tyner, for your presentation, and Dr. Eobuche for your contributions. I'm going to share my screen, and I hope you guys enjoy this video.
Hello, Black America, and people who pay attention to what Black folks are doing. My name's W. Kamau Bell. There's good news out there. There's a COVID-19 vaccine. Yay! But the bad news is, as Black folks, it's hard to trust what's going on. So what do? Well, we turn to people we can trust. Black folks. But not just your uncle at the cookout. No. Actually, not him at all. I'm talking about Black scientists, Black doctors, and Black nurses. Okay, first question. The vaccine happened fast, like super fast, like Usain Bolt headed to the bathroom fast. Is that something we should be concerned about?
Having an emergency authorization for these medications was critical, but that doesn't mean any steps were cut.
Anything where money could be traded off for time, that was happening. Like money was no object.
They still have all of the rigor that they use for approving any vaccine. So we can feel confident that the science is still there.
The messenger RNA technology has been in development for the last 12 years. So even though you hear this thing about warp speed, believe me, that was not warp speed.
And I think the data is real. It suggests it's highly effective.
About a week or so after your second dose, the people who had gotten the placebo or who didn't get the true vaccine, their rates of coronavirus continued to climb. Whereas the people who had gotten the vaccine, it just flattened out.
And what about side effects?
Soreness from the injection site.
I had a little bit of arm soreness.
Arm sore? Is that a side effect? My arm's sore right now.
The common things, soreness at the injection site, headache, fever, maybe a swollen lymph nodes.
The second dose is when there's more common, those systemic side effects.
Is this like one of those pharmaceutical commercials where at the end they talk real fast about the side effects and it's like, you're also gonna get hair from your eyeballs and vampirism?
My sister texted me the second day after I got the first vaccine, and I remember she was like, "Are you a zombie yet?" And we just laughed, like, "No, I'm not."
So the big answer is no. And the reason being is we are not injecting the virus into your body. The vaccine is training your body.
It is making those antibodies to fight that disease. So I view it as a positive thing.
So here's a question from everybody's uncle. And since I'm an uncle, it's a question from me too. Are the drug companies just trying to get rich off this?
The drug companies will certainly get rich.
Oh, drug companies are always trying to get rich, but that's not the point, right?
That is really how a lot of our innovation happens. That is why the drug companies will spend millions upon millions in research.
Were Black and brown people a part of this process, or was it only like white folks, like NASCAR white folks.
The trials were intentionally broad and inclusive.
Yeah, Black and brown folks have been recruited for the clinical trials.
We have ensured that each of the 4 historically Black medical schools, that we are all vaccine trial sites.
So here's the big question. How much are you charging us for this vaccine?
Right now, getting vaccinated is free.
Free?
Yes, it's free.
Like free.
It will be free.
Like not even free 99.
We have not charged anyone.
Okay, should I be suspicious that you aren't charging us?
No, because there are some things that the government invests in that for the good of the people.
Taxpayers like you and I contributed to the development of these vaccines.
What if I'm not worried about getting COVID-19?
Like you could say, I never had smallpox, I've never had tetanus, why do I need the shot? That's why we give vaccines. Vaccines are prevention.
I pretty much tell people you're going to be exposed some kind of way, right? So you better be ready to fight.
And what about you? Have you? Will you?
I got my first dose about 3 weeks ago.
I have not gotten the vaccine yet, but rest assured, I'm anxiously waiting.
I definitely will be getting vaccinated when my turn comes.
I was scared getting it, and then after I got it, I was like, oh, well, I guess it wasn't that bad.
When the vaccine went in, I felt this intense amount of honor.
Like a lot of people, I like to get my medical information from bizarre, dark corners of the internet that haven't been vetted. Is that a good idea?
Oh dear.
Please do not continue to do that.
That is definitely not a good idea.
Unfortunately, on the internet, pretty much anyone can post anything.
There are no microchips. There's no stealing of your DNA. No, none of that is happening.
Thank you, doctors. All right, I'll let you get back to work. And thank you for allowing me to ask you these questions. But before you go, just want to let you know, your parents are super proud of you. It's all they can talk about.
Thank you, Marcus, for that very informative video. I learned a lot off of that myself. So I didn't introduce myself before. I want to take the time to do that really quickly. My name is Danielle Combs, and I am one of the social justice interns for the Office of Academic Achievement Programs. I now have the pleasure of introducing 2 more amazing students to give their next student narrative pieces for today. The first one is Amanda Onyemwa. She's a senior going for nursing and minoring in gerontology. She won Miss Black during the 2019 Alpha Phi Alpha Fraternity Incorporated Miss Black and Gold Scholarship Pageant, and she currently works as a patient care technician on a COVID-19 floor. Following her, we will have Lillian Nickins. She is a junior double majoring in social work and Africana studies. She is also the co-founder of the First Osprey Student-Led Club. Amanda?
Thank you, Danielle, for that awesome introduction. Hi, everyone. My name is Amanda Onyemwa. I hope everybody's safe during these times. I know these times are very trying, so everyone hang in there. So like some people I mentioned before, I've spent like some years of my adolescence growing up in Nigeria, and I came back to this country for better healthcare with my sickle cell anemia. And with my experience with that, I kind of like had like a fear of like going to hospitals because I was frequently hospitalized when like I first came back here. And the treatment that I would get, like I would feel like I would like be bothering like my physicians or like my caretakers. And I didn't really feel as welcomed as like certain counterparts that I had in the hospital. So from that experience, I kind of wanted to grow up and like make a difference in the healthcare field myself. So I decided to go into nursing. As Danielle mentioned, right now I am a patient care technician at the COVID-19 unit at Atlanta Care. And there's just things that, you know, I see a lot of patients like every day when I go in, and I just see differences in treatment. I see everyone on my floor is like mainly like COVID positive, but there are some people that come in with certain diseases that are more often in Black communities, like sickle cell or having kidney diseases or anything like that. And I see a main difference between them and other patients is their pain management. I do see when, you know, they ask for like attention, saying that they're in pain or anything like that, they're kind of looked over, or kind of their pain is underestimated frequently. And as someone that kind of knows that experience myself, I and learned to self-advocate like as a younger adult, and not from the hospital. I kind of make sure that I advocate for these people as well. So a message that I just want to give to everyone here, no matter if you're a health science major going into medicine, or you're doing social justice, or whatever you go into, whether you're Black or not, definitely advocate for not just Black people, but everyone to get fair treatment, because we all contribute to society. We all pay taxes. We all do all that. So it's just fair that we all get proper and equal treatment that, you know, is equitable. So yeah, thank you for your time, everyone.
And Lily, thank you for sharing, Amanda.
Hi, can everyone hear me? Yes? Oh, because sometimes my sound goes out. So my name is Lillian. I am a junior, like Danielle said, double majoring in social work and African studies. And before I share my story, every time I would like think about African studies and this topic will come up, I will always go, wow, that's crazy. But until it happens to you, you don't even like recognize like how powerful or how much of a problem like this is. So really quickly, last May, this is during like not the middle, but like the turning point of COVID. Like this is when everyone is like super scared, super nervous. Oh my God, everything is COVID, 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 right? That's all you hear, COVID, wear your mask, wash your hands. And I had got really sick, like very, very sick, to the point of now that I know, back then, the doctors told me like I could have died. And I was in so much pain and I couldn't understand. I had a fever of 105 for days, couldn't talk, didn't eat or drink for like 5 days, so dehydrated. And my mom was like, listen, you need to come to the hospital. You need to do what you need to do and get here. So I was at Stockton. My mom drove down, came and got me, took me to the hospital. And at the time, you know, like your parents weren't allowed to like be in the room with you. You're not allowed to have anyone in the room with you. And I'm telling them, like, I told the doctor, I said, I really think I have a kidney infection. I think I had an infection that's made its way to my kidneys. All the symptoms are like, my mom was like, they sound like a kidney infection. And they just would not listen to me. They tested me for COVID. They gave me Tylenol to get my fever down, and they sent me home. And even when the doctor came in the last time, he was like, I was like, did you guys test my urine? You guys didn't test my blood, like anything. All of like the normal procedures they do in the hospital, they just didn't do. And so I said to the doctor, I said, hey, I think I have like an infection. I think you guys need to like test me. And he said, well, who did you tell that to? I said, well, I told you when you came in. And then I also told the nurse. He said, well, telling the nurse is no good. I'm the doctor. What are you telling the nurse for? I said, well, are you going to do it? He said, well, they're discharging you now, so there's nothing I can do about it. This was on a Friday. I ended up back in the hospital less than 24 hours later because I literally almost passed out, completely lost consciousness. I have really, really bad anxiety, which is another thing that's overlooked in the Black community, to the point where I couldn't even like speak for myself. I mean, I was in so much pain, crying, in and out of consciousness. And thank God I was at the hospital where my mom worked, because my mom had to leave her floor and come down and advocate for me. Like, look, she was just here less than 24 hours ago. There obviously is something wrong. And the fact that this one doctor overlooked her is a problem. And it took for my mom, this 4'11", very, very loud little person, to say something for them to be like, okay. And my mom was stayed in the room with me, even while she was on her shift. Like, she stayed there to make sure that they did the proper management. And it came back that if I had waited at least one more day, my whole body would have went into septic shock. And it's all because I went to the hospital and I said, listen, this is what's going on. You know, I'm in this much pain. And even as I'm in the hospital, I'm like, no, I'm in pain. They're like, oh, well, we can get, and I'm allergic to a lot of medications, but it was like, well, on a scale of 1 to 10. And I'm like, well, it's a 10. Are you sure? Do you sure it's not? And I'm like, I know what I feel. And I ended up being in a hospital for like a week and a half. And it was just so disheartening, even, you know, following up. And I've been dealing with this for about a year now, even following up on my doctors. They're always asking me like, are you sure? Are you sure? And I'm just like, well, are you sure the sky is blue? Are you sure the grass is green? Like, I'm pretty sure I know what's going on with me, just like you would know what's going on with you. And for a long time, like I felt very, very like uneasy about it. And even recently, I've been hospitalized like 2 more times after that, the same thing. And I'm always scared every time I go, because it's like, what if they don't listen to me? What if they don't believe me? And even when I sought out legal counsel, like maybe I should like just talk to a lawyer. The lawyer was like, listen, there's nothing we can do about it, because there's no proof that it was racial intent. There's no proof of that. And I'm like, well, how do you prove it? You know what I mean? Because I'm telling you that this is wrong. And this is the way that I feel. And I just want to say, like, just kind of like what Amanda said, like advocate for yourself, you know, like there's nobody else that's going to advocate for you. And my mom's actually on here. So I just want to say, Mom, thank you so much for advocating for me, for speaking up for me, because to be on the brink of death, I'm sorry, I'm so emotional, to be on the brink of death and you're laying in a hospital bed with 105 fever and they can't give you any fluids because your veins are like collapsing. They can't do anything for you. And you're laying there and then you're finally like, look, at this point, I don't know. And all of this could have been avoided simply by listening to what I said 2 days before. So definitely advocate for yourself. Be the voice that you want somebody else to be for you. And that's all that I have to say. Thank you.
Wow. I don't know about everybody else on here, but I am speechless. Thank you so much, Lily, for being vulnerable and sharing your story, because it's definitely something that we all need to hear. And some of us on this call have probably been through similar things. I know that I have. So thank you so much just for opening your heart and sharing that with us. We have our next 2 speakers. But before that, I'm sorry, I don't think I gave enough just due to Dr. Ehibuche and Dr. Milan Tyner, because both of them are very, very actively involved beyond just being faculty here. Dr. Ehibuche is co-founder and chief operation officer of Faith Family Healthcare, and he advocates for patient-centeredness in healthcare delivery, and he has published numerous journal articles related to the future of healthcare. And Dr. Milan Tyner is a well-known leader among the public and nonprofit sectors in the Greater Atlantic region. So I wanted to make sure that I, just kind of gave them their just due. And then, of course, next up we have Dr. Trina Gibson Jones, who is assistant professor of health sciences here at Stockton. She was also recently awarded a research and professional development grant for her food insecurity and known obesity risk factors in preschool age children. So that's some of the research she's doing. She received her PhD from Hampton University, the other HU, and she received her Master of Science degree from Hampton University in nursing. She is a nurse by trade. And so, she's very, very knowledgeable in this field. Dr. Ruffin, who is the coordinator of the Master of Science Nursing Program and assistant professor of nursing at Stockton, is also a practicing nurse. He's a nurse practitioner and certified tobacco treatment specialist, and he chairs the National Black Nurses Association's Smoking and Vaping Advocacy Committee. So you guys are being exposed to some, real scholars here, and I just wanted to make sure that I let you all know that. So next we will hear from Dr. Trina Gibson Jones.
I'm going to let Dr. Allison get away with that other HU, but hey, Hampton is in the house. All right. So you've heard a lot this evening from a lot of the esteemed colleagues that I have. And I'm so appreciative for the student accounts as well, because it touched me so much I got tearful, because I hate to continue to hear these stories. As a healthcare professional, it touches me greatly to know that my people or any people are receiving less than the proper treatment that they should receive when entering into a healthcare arena that is supposed to be about caring. And so when we fail to do those things for anyone who enters into the healthcare organizations, I feel very touched and saddened by that, especially as a healthcare provider of color. So as we move into this segment of the talk, I have a few objectives that I would like for you to kind of consider. We're going to discuss COVID-19 outcomes based on race, ethnicity. We're going to talk about the impact of healthcare disparities and comorbidities on COVID-19 outcomes in African Americans or Blacks. And we're going to use the backdrop of social determinants of health to look at how the COVID-19 experience is found within the African American community or Black community. You'll hear me say African American and Black because they're separate, and they are not separate as far as the data is concerned, but they're separate as far as what Dr. Milan Tyner talked about, culture and different places in which they come from. But their data are combined, unfortunately. So it's all about the data. Health disparities disproportionately impact African Americans or Blacks, as discussed previously in the talk earlier with our other colleagues. And unfortunately, COVID-19 has not differed in this trend. All ethnic minorities have shouldered more of the burden for COVID-19 deaths when compared to whites. I'm sure you're asking yourself why this is. It has to do with those social determinants where a person lives, plays, grows, works, receives his or her education, and worships. And so with that being said, it saddens me to say that race and ethnicity are markers for underlying comorbidities or conditions that affect health, such as socioeconomic status, access to health care, and also exposure to the virus itself is related to zip code or where a person lives and the occupation they occupy. These data indicate all minorities are more likely to be infected by, hospitalized, and die from COVID-19 at higher rates when compared to whites. And if you look at the New Jersey stats, while these data seem to indicate African Americans have lower cases when compared to their proportion of the New Jersey population at 11% of the cases and a higher number of deaths at 16%, which is disproportionate when compared to the population figure for the state at 14%. As the New Jersey does not provide good testing data based on race and ethnicity, that information is not included, but it does seem to indicate that there is a decrease. Other data tends to indicate that there's a decrease in testing as well for African American or Black communities. And one thing we should be thinking about is why might this be? Because of those historical and present day problems that African American and Black communities have suffered, as spoken to earlier in the presentations, this is a problem in regards to the higher numbers for African Americans and Blacks. And again, when we don't have de-aggregated data for COVID, it mimics or hides some of the information that would be more pertinent for us to study how much we differ in regards to race and ethnicity. All the data is not de-aggregated, and so we're not able to see truly the picture that we should see in regards to number, even though it is quite bleak what we can see. Long-standing systemic health disparities and health inequities and institutionalized racism allows persons from minority backgrounds to be disproportionately impacted by COVID. Social health determinants are also a main factor in regards to why African Americans and Blacks are falling on the low end of COVID risk factors, as far as being more disproportionately affected, I would say. And some of those things, as I discussed before, were the occupation, being on the critical frontline workers. We have a lot of African Americans or Blacks that work in grocery stores, they work on garbage trucks, they work in, some tasks that are going to be out there and not considered people that can work from home, so to speak. They have to still interact in the public with other people, which causes them to be exposed to COVID at greater rates than others who would have the luxury of being able to stay at home. Education and income gaps, which limit insurance options and flexibilities of jobs, as well as I mentioned before, institutionalized racism and discrimination. If you move forward and start looking at COVID risk factors and those things that impact African Americans, and so one of those things that you want to look at is the overall risk factors for COVID-19. And persons who are 65 years and above, have any lung issues, have heart issues or have diabetes, are obese, have weakened immune systems, these things make people more susceptible to COVID-19 and contracting the virus. And unfortunately, African Americans tend to suffer disproportionately from the majority of those disease processes that you see noted above. And so therefore, the impact is seen and is greater within that community. So some of the things that we can do, and I like to think about this because you don't want to just be thinking, okay, this is a problem, this is where we sit. Is there anything that we can do about it? Of course, there's many things that we can do. And I also want to say that it is linked to other historical and present day issues that we have had as an African American or Black community. As mentioned previously, the SIMS studies, gynecological studies that were done on enslaved Black women in 1899, W.E.B. Du Bois's book, The Philadelphia Negro, talked about health differences even back then, which weren't called really health disparities at the time, but that is exactly what he had uncovered in his studies in Philadelphia. And it was based on social condition, he thought, as well as the fact that they lived in inferior living conditions. And so those things still exist to this day. In 1913, there were sterilization laws that allowed mentally ill persons to be sterilized, and disproportionately that happened to be Black people more over than whites. The United States Public Health Services study of untreated syphilis, as was mentioned, Henrietta Lacks and the HeLa cells, John Hopkins' unethical treatment of her cells and obtaining those cells without her permission and utilizing them for research purposes. And then the present day racial injustices such as Trayvon Martin, Breonna Taylor, Sandra Bland, George Floyd, and unfortunately it goes on and on and on. These are reasons why there is hesitancy or reluctancy in the African American community to take in this COVID vaccine. And so what can we do? Some of the things that we can do is we can train people to be more culturally appropriate when interacting within the African American or Black community. We could also train a larger cadre of African American or Black healthcare providers so that people see people who look like them when they go into the healthcare organizations and arenas. We can also then be those advocates, as was mentioned earlier by one of the students. Speak up. If you see something, say something, those types of things. It's important for us to teach this type of activity, advocacy, and leadership skills in healthcare. So as a healthcare educator, I find it to be very important to have that kind of interaction with all students so that they know what is going on, what the numbers or the data says, and how they can be part of the solution and not part of the problem. And so these are some things that we certainly can work on and do. And then you saw the Kaiser Family Foundation's campaign to really get out into the community and meet them where they are, because we can't sit in our ivory towers, and wait for them to come to us. We have to go where they are, provide things in plain language so that it can be understood. We don't want to label people as being hesitant. We want to say that they have legitimate concerns, because historically and present day has shown them that there is reason for concern. And so we don't want to negate their feelings nor their concern. We want to address them and make sure that we're giving them proper information and education so that they can go out and make informed decisions. I think that's my time. I thank you so much. I have a few references, more on the next slide, and more that I provided Nordia, if she would like to add those to anything that's sent out. And I thank you for inviting me tonight to talk to you. Have a good one, everybody. I'm gonna be here, listen to the rest, and then the breakout rooms. But I enjoyed it. Thank you.
Thank you so much. Dr. Ruffin.
Good afternoon, everyone. Thank you so much for the opportunity to be part of this panel discussion. And I truly appreciate all the speakers, the students. And thank you so much, Dr. Allison, for this warm introduction. And Trina, you already covered many parts of my presentation, which is great. So guys, I'm here to quickly talk to you about the effects of smoking and vaping on COVID-19. This is a smoking and vaping. These are some topics that I am very passionate about. And, anytime I have an opportunity to speak about smoking and vaping, I'm always really thrilled to do so. So by the end of this presentation, you guys should be able to state at least one impact of smoking on COVID-19, and also 1 to 2 advertising strategies that have been used to promote smoking and vaping into the my African American population. So quickly, smoking. If I would ask you now, if you know anyone who smokes, I'm sure all of you would raise your hands, whether it's a close friend or a family member. Unfortunately, a lot of people smoke, and why smoking is such a concern. So right now, that slide you have in front of you shows you just how, so let me go back here. I mean, the brain, okay, developed, okay. So basically here it says judgment lasts to develop. So in reality, the younger the brain, okay, so the less judgmental, okay, or the less judgment, okay, that can be performed. So really the executive function of the brain, that's something that really comes with maturity. When you are young, a lot of times, we think, our parents maybe, they think they know everything. Well, something with their brain development, there are a lot of things they know as you become older. As you can see here with these pictures, the more red, okay, or yellow is the brain, okay, the less mature is the brain, and the more vulnerable is the brain. So you can see even a 20-year-old brain, okay, still has some some areas of like, a greenish to yellow areas. So the brain is not fully developed until you are around like the age of 25. Okay. So when you introduce like smoking, okay, smoking to the, to the brain at an earlier age, it damages the brain. Okay. Now, why do people continue to smoke? When you smoke a cigarette, right? You inhale the cigarette, okay? It takes about 7 to 8 seconds for that nicotine to draw back, into the brain, okay? And the person feels good for a few seconds, and then your brain is asking you for more. Right now, you guys can see this on the slide here. Tobacco smoke contains a deadly mix of more than 7,000 chemicals. Okay, so actually, if I was in a class with you, I would have, asked you guys to give me numbers. What do you think? How many chemicals? I barely get that number here. 7,000 chemicals, and 70 of them are known to cause cancer. Okay, so there are a lot of known chemicals in a cigarette. Okay, a lot of really bad chemicals, things you wouldn't even touch. Yet many of us are using them or inhaling them. Okay, so you have like 7,000 chemicals. Now, when you hold a cigarette in your hand, that cigarette doesn't have 7,000 chemicals. But when you light that cigarette, okay, the effect of combustion, and many of you have taken a chemistry, okay, you have more chemicals, okay? So that's why when you light a cigarette, you have that many chemicals in a cigarette. Unfortunately, guys, the African American population has been targeted, in ways that are totally different from any other ethnic groups. These are some images from different cigarette boxes, okay, that have been really targeted to the African American population. Look at that, so cool. It's so good to be cool, huh? I mean, look at this here, okay? All Starrington smokers would rather fight than switch. So these are advertisements targeted to the African American population, having African American stars, okay, smoking, okay, like people that many of the African Americans, look at as legends, of people that we love, okay, are the ones that are being used, into these boxes of cigarettes. And of course, there are people we like. So therefore, we are buying the cigarettes. When it comes to mentholated cigarettes, for example, the African Americans, they love menthol cigarettes. It's unfortunate that the menthol cigarettes have been particularly targeted to the African American population. Okay, menthol is easier to start and harder to quit. So one thing that happened with menthol is that menthol really numbs your throat. Okay, so when if you take like a cough drop or a cough syrup, okay, it has menthol in it. Okay, so that numbs your throat. So now the tobacco industry is very clever. So what they did in the 1950s, when people started smoking and people were coughing so much, that's when their chemists, team got together and said, okay, well, okay, so let's put menthol into in the cigarette, so that when you inhale it, it will numb your throat. Therefore, you won't feel it, so you won't cough that much. In fact, that's one reason why we see when someone smokes, and especially with mentholated cigarettes, after they quit, that's when they start developing a lot of coughs. Then that happens because their throat starts to heal, and because it starts to heal, that's when, of course, the body is always trying to get rid of all these abnormal a bacteria. So the body try to repair itself and coughing out these substances. So Black, young, or poor, so you are being targeted because a lot of people, unfortunately, a lot of more African Americans died from cigarettes than any other groups. So with COVID-19, guys, actually, we are seeing a lot of people, despite everything that's going on, people are going out and continue to smoke. Okay, let me look at this picture here with this gentleman. Okay, all right, so the mask, okay, the mask is down to smoke that cigarettes. But the other thing is with your hands, when you're smoking, okay, you have your hand touching everything else, but you put it in your mouth. Okay, you are getting the virus. And the other thing is that smoking, when you smoke, the fact that the cigarette has so many chemicals, okay, those chemicals really damage your lungs, okay, damages your lungs and other parts of your body. So the chemicals from the cigarettes really weaken your immune system. And by weakening your immune system, you become more vulnerable to catch any type of health of illnesses, especially a pulmonary infections, and of course with a COVID-19. Okay, so if a person who smokes catches COVID-19, they are more likely to develop severe cases of the virus than those who do not smoke. Flavored tobacco products also makes the lungs like a very similar to COVID. Actually, if you guys can remember, like in October and November 2019, we had a lot of vaping related deaths in the country. Of course, with COVID, right now, they don't talk much about that, but a lot of the symptoms are very similar to COVID, except that with the lungs damage, we see a lot of popcorn lungs, with using electronic cigarettes. So that makes it even harder. So when you smoke, so if there is a time that people should quit smoking, he would say is the time is now. If there's a time to stop vaping, that time is now. And as Dr. Gibson Jones said earlier, the African American populations, I mean, we died more from COVID related deaths than, we died more from COVID than any other race. I mean, think about the number of African Americans we have in the country. Okay, I believe what African Americans make probably what is it one third, or no, not one third, probably is it like maybe like 12% or so? Okay, don't quote me. About 12% of the population is African Americans. But look at this here. Oh, now this data was from July. Okay, that's the that's what I could put my hands on. Now, a blue is for white. Okay, and orange is for Black and green is Hispanic or Latino. Now look at us, African Americans, okay? With every category, you have more African American died from any other category. So think about it. Well, we only make up like about 12% of the population, and we are dying more from COVID-related deaths. Okay, so if there is something that can be done for us to not die from COVID, okay, I would do it. And unfortunately, smoking really weakens your immune systems and make it really hard to quit, and make you more susceptible to smoking. Now, look at this here. The tobacco industry is so clever that they are doing everything to make sure people continue to smoke. Okay, maybe you've never seen any of this here. Okay, look at this here. My first vape pen. Okay, my first vape pen. 9 months. Okay, not 9+ months. Okay, and this is here Vita Vape. Okay, vitamins. Okay, okay, kids. Okay, look at this. Vitamin enriched e-cigarettes for kids. Maybe you haven't paid attention to this. And look at this. Tastes like real fruits. And it has trace of nicotine. And we already know what's happening with the brain based on the earlier slide, that the brain is not fully developed. So now if you start exposing kids, to these chemicals, we are creating a larger and a much worse population of addicted patients. So this is what's happening with vaping. So what can you do? Okay, so we cannot just sit down and don't do anything. That's why right now there is a course you can take here at Stockton. That's called Smoking and Vaping. That will educate you a lot. Actually, it's a G course. I believe it's a GSS. So anyone in a health-related major can take this course that I teach. The smoking and vaping across the continuum. Okay, so I'm showing you this picture because I get involved beyond the little corners of South Jersey. So actually, NBNA stands for National Black Nurses Association, and Dr. Allison said earlier that I chair the National Smoking and Vaping Advocacy Committee within NBNA. So with my work, the NBNA has been able to influence members of Congress and to advocate for ban on nicotine and tobacco, and especially with mentholated products to the African American population. And that bill was passed in January 2020, right before the COVID. So we can do something. We can talk to our peers when they are smoking and vaping, and remind them that we can do something by stopping smoking or by stopping vaping. Thank you so much for your time, and I look forward to a lot of questions.
All right, thank you so much to all of you. I recognize that many of you might have questions for all of our presenters, and so I think the best use of our time at this point is to place you into your breakout rooms, and you can ask your questions there. Each presenter will be paired with a student, one of the wonderful students you heard from this afternoon, and they'll be fielding questions from you all, but they also have some discussion questions to pose to you. So Danielle, our wonderful social justice intern, is going to go ahead and open the breakout rooms at this time. I ask you to accept the invites as quickly as possible so we can get you going with your conversations and get you back to the main rooms soon as well. Thank you very much. I just want to thank you all so much for joining us this afternoon. It's been an immense pleasure to hear from all 4 of our presenters, and particularly from our students. It is not always easy to be vulnerable and to share your hearts in even spaces where you see people like you. Sometimes it's still nerve-wracking and it's still a challenge. So I want to thank you all so much for sharing. And thank you to all of you who came out this afternoon to continue this conversation. Thank you, Dr. Allison and Marcus Johnson, for facilitating today's session. We are looking forward to continuing this conversation with our next session on Black mental health matters and our final session on Black culture matters, which I am particularly excited about. I hope that you all will continue to be a part of these conversations to move our community towards actually affecting change as it relates to Black, Indigenous people of color, not only here at Stockton, but beyond our institution. Continue to do this work in your classrooms, in your programs, and in all the spaces that you occupy. As Dr. Gibson Jones mentioned earlier, I have a range of resources that I've collected from all of the speakers throughout the series that can assist you in continuing this conversation. So if you are interested, please do not hesitate to reach out to me. They will be archived on the Academic Achievement website at a later date. But if you want them in the meantime, please do not hesitate to contact me. I am most willing to share those with you. We are just about at time, so I hope you all have a wonderful evening, and I will see you back on March 24th for our session on Black mental health. As I said earlier, I am, go ahead.
There was a request for the contact emails for the presenters to put in the chat so that people can know how to reach them.
Awesome, thank you. If you all don't mind, our panelists, please go ahead and place your emails in the chat. I will also, once I send out the campus-wide email, I'll be including their names. So you'll have that as well as reference. As I mentioned earlier, I really do hope that you all will come out to future sessions. You have a wonderful afternoon, and please feel free to visit stockton.edu/academic achievement for more information about this series. My name is Nordia Johnson, and I am especially happy that you joined us this evening.